It's my pleasure to welcome you today to the Skill Building Workshop, Equity in Health Research. My name is Muntasser Kamal. I'm the Program Leader for Health Research Partnerships at Canada's International Development Research Centre. We have a distinguished list of speakers today, all part of the Innovations in Innovating in Maternal and Child Health in Africa initiative, MCHA for short, an 8-year initiative funded by IDRC, Canadian Institutes for Health Research, and Global Affairs Canada. MCHA is unique in its design. Each of the 28 implementation research projects in 11 countries under this initiative have an African principal investigator, Canadian researcher, co-principal investigator, and the co-principal investigator from a decision maker in the country where the research is taking place. The whole world is now experiencing life with COVID-19. Initiatives such as MCHA have many lessons to share for the response to COVID-19. For example, the race to find a vaccine against COVID-19 has demonstrated the importance of international research collaboration. MCHA research teams have been working together for many years, Canadian and African, and are well positioned to share the lessons learned from their collaboration for now and for the future. COVID-19 has also shown the implications of population health of ignoring and not understanding well the relationship between health and social inequalities and inequities. MCHA has a few experiences to share about that that will hopefully be of interest to our audience here today. Here to speak to us about this today is 3 distinguished researchers representing 3 research teams in MCHA, presented in no particular order. Dr. Fatuma Manzi is a lead researcher in health systems, policy analysis, cost effectiveness, and quality improvement. She has over 20-year research experience in the field of maternal, newborn, and child health. Her other research areas include human resources and community health systems. Fatuma sits on a number of national level advisory and working groups in Tanzania, including the Ministry of Health technical working groups, quality improvement, community health workers, and district health system groups. Dr. Manzi is a principal investigator on MCHA projects in Tanzania. Dr. Ronald Labonte is Distinguished Research Chair in Globalization and Health Equity and Professor in the School of Public Health and Epidemiology, University of Ottawa, and Professor, College of Health Sciences, Flinders University, Australia. His research focus includes, for example, the health equity impacts of health worker migration, global health diplomacy, tobacco control, health impact of trade treaties, primary healthcare reform, and the social determinants of health equity. He's active with the People's Health Movement and consulted extensively with UN agencies, governments, and civil society organizations. Dr. Labonte is Canadian co-principal investigator on the project on a project in Ethiopia. Mrs. Yagana Gidadu is the retired Director of Nursing Bauchi State. She is in Nigeria. She is an executive member and the health team leader of the Federation of Muslim Women Association in Nigeria, Bauchi State chapter, of which she was the president until 2018. Yagana has extensive professional expertise as well as strong experience in project management and implementation. Mrs. Gidadu is principal investigator on projects in Nigeria. The format of this session will be as follows. I will introduce some concepts that are relevant for the subject matter of our gathering here today on equity in health research. We will then have 3 rounds of questions for the speakers who will highlight how these concepts influence their research projects and what lessons learned they would like to share with you. Thank you very much for being here with us today. I hope you enjoyed the session. And now with those introductions, now we move on to our first round of questions for our speakers, and I'll do a little introduction as I mentioned earlier. It's not uncommon in the discourse about global health to hear about health equity being important and to hear different research entities or implementing organizations speak that their projects target vulnerable populations. But I want us today to unpack these concepts for our research-oriented audiences, to explore what do these concepts mean in the context of research, and especially for research on maternal and child health. Take, for example, health disparity, which is the difference that affects a person's ability to achieve their best health. Examples of health disparities include race, gender, education, income, disability, geographic location, sexual orientation, and others. Health disparities create health inequities, and the common view is that a health disparity is often beyond an individual's control. Two concepts of particular interest here refer to how these health disparities can be addressed: health equality and health equity. Health equality means everyone has the same opportunities. Examples could include a community center offering a free or low-cost checkups for everyone. Health equity means that people have opportunities based on their needs. An example could be the same health center charging people based on their ability to pay. A person who cannot afford care may receive it for free, while another person may pay for the same care. In short, health equality means everyone receives the same standard, while health equity means everyone receives individualized care to bring them to the same level of health. I like the way this was put succinctly in the 2010 Marmot Review, that quote, health inequalities are not inevitable and can be significantly reduced, end of quote. Regarding the hard to reach and those left behind, and in committing to the realization of the 2030 Agenda for Sustainable Development, member states agreed that the agenda's goals and targets should be met for all nations and people, and for all segments of society. This was translated to an aspiration to reach first those who are furthest behind. Ensuring that these commitments are translated into effective action requires a precise understanding of who these furthest behind populations are. However, the disaggregated data needed to address all vulnerable groups, including children, youth, persons with disabilities, people living with HIV, older persons, indigenous peoples, refugees, internally displaced persons, and migrants, as specified in the 2030 Agenda, are sparse. Few of the current indicators, for example, are able to shed light on the particular situation of these populations. Even from the limited data currently available, it is clear that the benefits of development are not equally shared. For example, some couple of relevant examples. In every developing region, the poorest women are least likely to have a skilled attendant during delivery. In Southern Asia and Sub-Saharan Africa, fewer than 30% of births among women in the poorest 20% of households are attended by skilled health personnel, compared to over 80% of births in the richest 20% of households. Globally, in 2015, births in the richest 20% of households were more than twice as likely to be attended by skilled health personnel as those in the poorest 20% of households. This is my little introduction, but we now want to hear from our speakers. So with this in mind, I now turn to our speakers to ask them my first question. Your research, your projects explicitly addressed equity and vulnerability. Could you briefly, in 5 minutes or less, describe what your project is about and how you are operationalizing these concepts in these projects? We now go to our first speaker.
Okay, thank you very much for the brief. Our project is a collaboration between the State Primary Healthcare Development Agency, Federation of Muslim Women Association in Nigeria, Bauchi State Chapter, and CED Pram in the University of McGill, Canada. The aim of this project is to implement major maternal child health using local evidence-based universal home visit to pregnant women and their spouses. It's a cluster randomized trial, controlled trial, cluster randomized controlled trial, and then male and female were trained to register all pregnant women talk with all pregnant women and also discuss with husbands of pregnant women on issues related to pregnancy and childbirth. They visit the community and then reach those pregnant women and their spouses every 2 months. Then they also visit them when the woman is throughout the pregnancy every 2 months, and then they also visit the woman after she has delivered 1 year, and again when the child is 1 year. So giving all these visits, and then they use an evidence-based docudrama to interact with the pregnant women and their spouses. Then in overall, we were able to reach 36,000 households, and then about 26,000 pregnant women, and then 2,170 child of 12 to 18 months. So the impact we measured showed that maternal health has improved, child health has improved, and it has also changed the attitude and behavior of men towards pregnancy and childbirth. So vulnerable and hard to reach populations, the key issue with our facility base is that they are unable to reach the most vulnerable group of women who really need the care. Even the outreaches that are being made by the community health extension worker, they always find it difficult to reach the vulnerable groups. Our project deliberately was able to reach every household, everybody, including women, spouses, child, and then in the target community. We also work closely with the local government authority. We demarcated 300 households to each of the team of a female and a male who will move around discussing with them. And we also use Android handset to record the information and GPS to track whether or not they are being able to reach those houses. So this is the one sure way of getting to the pregnant women and their spouses to discuss issues around that. Then reaching remote community was a challenge actually. Challenge in the sense that initial visitors were unable to reach the households. We had to re-strategize to train those within the community who are being also nominated by the community leaders, so that they will be there to give the services. And then in equity, like you said, equality makes services available equally, but equity requires special efforts. And those special efforts, we have steps that we took to ensure equity is done. That is recruiting the people who are working, that is the young men and women who will work within the community, from the community. Then at the same time, use GPS to monitor and ensure that all the vulnerables are not left out. They are all houses are, they entered every household without missing any. And then they also respected the community norms. Therefore, they are likened by the community. And then we visited the spouses, the men, because men involvement is part and parcel of bringing equity. Otherwise, especially gender equity. Then focus group discussion we conducted reveals that every household has been reached, no household is missed. So this is how our project and how we were able to tackle the issue of vulnerable as well as providing equity to everybody.
Thank you so much for your very clear example. Now we'll move on to our next speaker to also hear about their experience and their views. Thank you very much.
Thank you.
Our project Quartz was addressing quality improvement at this scale in southern Tanzania. We were working to bring about health system strengthening for maternal and newborn health. The project Quartz utilized electronic tool in collecting health management information system. During implementation, we worked collaboratively with stakeholders to put emphasis on the culture around data collection and data use at the point of collection. Of course, it was inherently that people are just sending data to the district level, but our project emphasized that the data should be used to inform coverage, to inform service delivery. So together, we developed measures of quality maternal and newborn care that can routinely be collected, and we strongly underlined those that were sometimes not analyzed at the point of collection or even at district level for further action. So we addressed the concept of equity and equality through first thinking of the study population. We worked in the remote district, in the border, southern border of the countries, and we also worked with vulnerable groups, women during delivery and postnatal. Also, we targeted newborns. Yeah, those are the areas we thought of equity.
Great. Thank you very much for your answer.
Well, our project was attempting to improve maternal health outcomes primarily, but also maternal child health outcomes. And we took a look and sort of working with our partners in Ethiopia, in the Jimma zonal district and through Jimma University, we wanted to find out what were the major barriers to women seeking assisted or skilled delivery in a health center. What we found out, of course, is that one of them is geographical access, that they're too far away. And by the time they approach labor, it's difficult for them to actually physically get to the health center. And this is particularly so given the poor state of the roads, the poor state of the communication facilities, and so on. So we wanted to say, well, how could we improve that? So we looked at two interventions in a kind of a cluster randomized intervention trial. We looked at two interventions. One of them was, first of all, to improve the information or education and communication outreach of health extension workers, zonal health department people, the Women's Development Army, the Men's Development Army, religious leaders. We wanted to increase the understanding or awareness around pregnancy, around prenatal visits, around the importance of skilled birth delivery in a health center. So that was the kind of outreach component to stimulate, in a sense, demand. But then we also had to look at supply. And a key factor here was to look at maternal waiting homes, or what we sometimes call maternal waiting areas. Those are part of the structural programmatic elements in maternal child health programs in Ethiopia. So each health post is, or not health post, but actually each primary health care unit, the health center, is supposed to have a maternal waiting home, in which case women who are further away could go to the maternal waiting home and await delivery at the health center. So they didn't have to rely on just suddenly going into labor and not being able to get there, and all the risks that might entail. So we wanted to look at upgrading these maternal waiting homes because they were in pretty sad shape. None of them had the full capacity to actually function as they were supposed to. So that would become an impediment, and we knew that from initial study in the area that was a barrier to women wanting to even access those maternal waiting homes because they didn't have electricity, they didn't have running water, they didn't have people to sort of help out and sort of serve with the meals or the coffee ceremonies or any of about 9 or 10 other essential features that these maternal waiting homes were supposed to have. So we set about to try to improve both of those aspects and to overcome those particular barriers. Now, when we think about vulnerable populations, we don't like to think about vulnerability that way. Not vulnerable people, because that implies there's something necessarily wrong with them. We like to think about conditions of vulnerability. What is it that creates vulnerability in some people and not in others? One of the critical ones, of course, that we discovered or encountered was the geographic barrier, that families in Kibeles that were further away from the health centers had more of a challenge trying to access them, even to get to maternal waiting home in time. And when we talked about equity, we were concerned about not just equality, of course, is the measure of sameness, but equity is some aspect about how fair the distribution of different resources were. We saw that in one instance where in one Kibele area, they were complaining that a health center that belonged to another kind of region or kind of another group, as it were, not the one they were supposed to go to, but it was very close to them, but they weren't kind of allowed actually to sort of use it. They were supposed to go to a health center that was much further away. They thought that was unfair. So that's one of the ways in which equity sort of arose. But what we began by doing a lot of community questioning, a lot of focus groups, some key informant interviews. We wanted to find out from the participants in this study, from people who these interventions would actually serve, how well did they look at what it was that caused health in the first place? What was important to them in terms of being healthy? How did they understand what was being fair or unfair in their local communities? And we discovered a few things that were kind of interesting. At the community level, we found that there was a very good understanding of equity, not necessarily the term, but a very strong sense of solidarity, that they emphasized continuously the value of different forms of sharing or mutuality. In some Kibeles, they pooled money or resources, and then they would be allocated to different individuals within the Kibele according to what they needed. And then we also found out when we went to talk about this at higher levels, about this understanding of equity and equality, we found that at the ministerial level, a lot of the emphasis was placed on equality. That what they were looking at was a measure of difference. What they wanted to see is where all of the different districts, where all of the different kind of catchment areas of the primary healthcare units, the health centers, do they all have an adequate number of health posts? So it was all about sameness. It was all about rolling out a project or a program that would be the same everywhere. And that was a bit different. We found it kind of a little bit different when we got closer to the ground. So if we looked at the health extension workers, if we looked at some of the staff who were working for the zonal health department, one of the things that we found quite interesting was their attempt to try to redirect some of the resources they had. So they were trying to cut costs. They were trying to redirect some of this funding to other sources where it was needed. So they engaged in a kind of a bureaucratic form of creative reallocation. And they really wanted to learn how to do this better. They wanted to get the best equity practices of their health system out in the open. They wanted to be able to discuss more this kind of creative way of working at local levels with the kind of resources that they thought would be fairer in terms of overcoming some of the barriers that women and families faced in terms of having a safe and healthy childbirth experience. We actually even found that several health workers and some of the directors at these health centers would sometimes give some of their salary directly to those families in need. In order to acquire or else to acquire resources for the health center or for other public goods. So in that sense, there was a really strong sense or grounding of equity understood as an action rather than as a concept. And we found that in our workshops that we developed to train religious leaders, health extension workers, and so on, in terms of preparing them to go out and spread the message, as it were, more effectively or more comprehensively in the communities, that we based a lot of that on experiential learning so that we can really tap into their understanding of fairness.
Thank you very much, Ron. This is a really great example and very clear explanation of these concepts and application on the ground. Thank you for that first round. I think it was very interesting, and I am hoping the audience will come back in the Q&A segment with many questions for you. Now we move on to our second round, which talking about issues related to intersectionality and social determinants of health, which are key concepts for when talking about health equity. The influence of social factors on the health of populations has been the subject of study and extensive research for several decades now. Yet we still have many health inequities and people left behind, as we have heard in the first round. Many observers contend that this is because there is not enough attention to how these social factors interact with each other and how they in turn interact and influence the health of groups within the larger populations. One of the framing concepts to unpack here today is the concept of intersectionality. The concept speaks to the interconnected nature of social categorizations such as race, class, gender, as they apply to a given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. Intersectionality is the acknowledgement that everyone has their own unique experience of discrimination, and we must consider everything and anything that can marginalize people, gender, race, class, sexual orientation, physical ability, etc. First coined by Professor Kimberly Grinshaw back in 1989, intersectionality was added to the Oxford Dictionary in 2015, with its importance increasingly being recognized in the world of women's rights in particular, and health, global health as well. The Oxford Dictionary defines intersectionality as the interconnected nature of social categorizations such as race, class, gender, regarded as creating overlapping and, as I mentioned, interdependent systems of discrimination. Intersectionality is closely related to another sister and older concept, the social determinants of health. The social determinants of health are the conditions in which people are born, grow, live, work, and age, according to the World Health Organization. These conditions, socioeconomic position, residential location, environmental living conditions, occupational risks and exposures, health risks, and health-seeking behaviors, along with the limited access to medical care, contribute to disparities in health status and health outcomes for certain individuals and groups. Put another way, the social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, work, live, and age. These forces and systems include economic policies and including policies and systems, development agendas, social norms, social policies, and political systems. The social determinants of health have an important influence on health inequities, the unfair and unavoidable differences in health status seen within and between countries. In countries at all levels of income, health and illness follow a social gradient. The lower the socioeconomic position, the worse the health. The list of examples of social determinants of health which can influence health equity positively or negatively include, for example, income and social protection, education, unemployment and job security, food insecurity, early childhood development, social inclusion, social structural conflict, and access to affordable health services of decent quality. Numerous studies suggest that social determinants of health account for about 30 to 55% of health outcomes. In addition, estimates show that the contribution of sector-wide health to population health outcomes exceeds the contribution from the health sector alone. Contribution of sectors outside health to population health outcomes exceeds the contribution from the health sector alone. These are still ongoing deliberations on the basis of more and more evidence, and more evidence is still needed and being generated to unpack the interactional and intersectional nature of health. But we have a vivid example we're living it now. We have seen these most starkly and most recently in the case of COVID-19. Many social determinants of health, including poverty, physical environment, and race, ethnicity, have and had considerable effect on COVID-19 outcomes. An example from the US, even in Chicago alone, over 50% of COVID-19 cases and almost 70% of COVID-19 fatalities are disproportionately within the African American population, who make up only 30% of the overall Chicago population. Moving forward, as the lessons of COVID-19 are considered, social determinants of health must be included as part of pandemic research priorities, especially in relation to maternal and child health and reproductive health. So why is it important, and what has this to do with maternal and child health? Without an intersectional lens, our efforts to tackle health inequalities and inequities for women's health are likely to just end up perpetuating systems of inequalities. The work towards women's sexual and reproductive health and rights must be intersectional. Any research that is focused on unidimensional experiences will fail to achieve the benefits of SDG 3 and SDG 5 on health and on gender equity and gender equality. To shed light on some of the relevant experiences from MCHA, I go now to our speakers to ask them my next question, which is, to what extent have your projects been able to engage with the concepts of intersectionality and social determinants in designing and implementing them? Please provide some examples for our audiences.
Okay, thank you very much for the brief. Toro is the local government where we worked, and Toro is a homogeneous community in religion and in ethnicity. Most of them are Muslims, and then also they are Hausa Fulani in ethnicity. We made a special effort to reach rural remote communities as much as we were able to reach others. We visited all households, irrespective of religion, ethnicity, whether poor or rich, whoever you are, we will go into your house, and we included everybody without missing a single house. Home visitors seem as liked by the community because we recruited them from within the community, so they are like us, like themselves. So they are part and parcel of the community, and that gives a lot of encouragement and also confidence in the people that are working with them. And then we repeated visits. We kept on visiting them every 2 months for over almost 3 to 4 years. So that also built relationship between us and them, and then there was no any problem, and that has also taken care of intersectionality. And then involving all co-wives, like for example, where there are more than one wife, we don't just talk to one, we'll talk to every one of them, and we encourage all of them to, put themselves together to help the pregnant woman among them. So that also gave them, instead of competition, they became friends among the members. Then we also increased communication between husband and wives on issues related to pregnancy and childbirth. And that also gave them a wider benefits, especially to the women. So the social determinants of health include factors actionable at the household level or community level. We did not import anything from anywhere, but we wanted to look at the upstream risk factors within the family home level, so that they will be able to solve it by themselves. So the home visit share evidence about upstream risk factors for maternal and child health, and we did not urge them to go to any health facility. But in any case, still at the end of it, we are able to see there was change in the maternal health and child health outcome. And then we focus on risk actionable household, especially with male involvement. So we were able to talk to the men on heavy work during pregnancy, domestic violence, lack of spousal communication, and then lack of knowledge related to danger signs. We also visit and share information on childhood immunization, diarrhea prevention and management in the home, and then we focus on community group. Community focus group reported there's change in the community dynamic. Community, the way they mingle. Example, men to be seen as undertaking some work that is being done by the women, especially when the women are pregnant. For example, like bringing firewood for the family, even washing of the children's clothes and so on. Men are undertaking on this, helping the pregnant women. Then men also stopped beating their wives. They are no more beating their wives. In fact, in some of the community, it became taboo for a man to beat his wife. So the community leaders are even taking it themselves to, come in and solve the problem. Then households and community are empowered to change the determinant of health within. It became the determinant of health, the risk factors, upstream risk factors at the home became part of the, the community leaders to be able to discuss it and then disseminate it among themselves and ensuring that such unwanted vices are stopped at the home. So this is how we were able to take care of intersectionality. In intersectionality and social determinants of health within our community. So,
thank you very much. These are really great examples of how this work is done exactly at the community level, very localized and very, very interesting. Thank you very much.
Yeah. In terms of social determinant of health, we consider the key stakeholders as well as the context in which the services were provided and the clients were coming from. So as I said, we considered clients from hard to reach areas. We included clients from semi-urban areas as well as those from rural areas. And also we considered implementers at different levels of the health system from the region who are making major decisions, the implementers at district level, services providers, and community leaders. So these people had different roles to play, and inclusion of all these groups made sure that we cater for various needs of various members of the society. And these stakeholders have different roles. As I said, at community level, they know their people, they know the nature of the problem. So as scientists, we provided technical backstopping. So during the design of the strategies, implementation, we work so closely, and at community, we created a group of champions. These champions took the front line in identifying the key challenges faced by women in accessing maternal and newborn care, as well as postnatal. And we together thought of different ways. For example, if women came and they didn't prepare well for delivery, because some, the delivery kit for very not well capable families, sometimes they come without anything, and supplies, they are not always available. So leaders at community level could identify those and recommend. At facility level, there were the leaders, implementers, as well as there are the social development person who were screening those who needed special help. And also social determinants were addressed through thinking about champions. I mentioned about champions, leaders at community level who were developing specific solutions for the people in terms of making sure that these people are well covered with the interventions. Like when women were coming late for the river, they came up with solutions to make sure that there are appropriate message that were delivered by community volunteers who were reaching out to women groups in the community, also to individual women at household level. For the health workers at health facilities, they were meeting through quality improvement sessions to identify what were the obstacles for the delivery of services, and they, together with the leaders from the district level, developed strategies to make sure that services were available and women were provided the services at the right time. All women to make sure their weight were recorded. They were checked for blood pressure. They were checked for HB, and all those were recorded. As I said before, we had this electronic tool. This tool made it easier for health workers at the facility to record the various indicators, and these informed decisions if the women needed referrals or they could be serviced there, or if there were any missing equipment or supplies, to make sure that women received the appropriate quality care on time. And also through quality improvement, we were able to deliver the right care because it was used as a platform to motivate health workers to feel that they have to do their job right. They have to do review meetings daily after their daily work. At the end of the day, they sit down and analyze their work of the day to make sure they had the right supplies and equipment. If there were specific cases that they needed support from district level, they worked together. Yeah.
Thank you. Thank you very much. You raised really important points about collaboration between the workers and the health services themselves, and also about tailoring the services to women, and also about sort of ensuring quality at the same time. So I'm really hoping we come back for maybe further elaboration in this in the discussion section. Thank you very much.
Thanks, Montasur. And yes, this alongside the equity equality issues in our study that we were trying to get at in terms of people's experience, we were very concerned about the intersectional nature of inequities. That it's not just a single dimension of unfairness that we needed to pay attention to, because there's a bit of a tendency, especially around programs that are developed for maternal child health, to deal with the gender dimension. But there's also geographic inequities, there's income inequities, there is even kind of interpersonal relationship inequities. And one of the things we actually found more on the quantitative side of our findings is that there was quite a difference in terms of access to or use of maternal waiting homes, depending on how wealthy families were. So wealthier families tended to use it far more often than poorer families did. That people or women who kind of felt that they had strong support from their family or from their communities tended to use it more than those who felt that they had very little support. Women who were more likely to be, as it were, housewives rather than having to be employed or working elsewhere were more likely to use maternal waiting homes. And kind of curiously, if you lived very close to the health center and to the maternal waiting home, you tended not to use it. But also, if you lived more than 5 kilometers away, you were too far away. You'd be too absent from your family. So here we have a whole set of intersectional determinants of inequality, of inequity, just around the issue of access or utilization of maternal waiting homes. All of our kind of research work, every time we went out to try to gauge what was happening in terms of our baseline studies, our endline studies, the qualitative and quantitative questions, we would always pepper that with a lot of different research questions. As I said earlier, about what makes them feel healthy. What is it that actually improves their well-being? And usually, I mean, they will talk about the different determinants of health. They'll talk about poverty. They'll talk about income. They'll talk about distance, lack of access to the kinds of resources that they would need. And when we tabulated this, because we also had a lot of discussions with the focus groups, with the development armies, with the Women's Development Army, the Men's Development Army, with the religious leaders, when we took all of this stuff together, I found that in terms of their understanding of determinants, they talked about individual attributes. So something that they felt was important in terms of maternal health was the number of children they had, their sense of their own power or self-efficacy, whether they had previously experienced a pregnancy or a health complication. And in family and peer influences, this was really about decision-making. Did women feel that they had the ability to negotiate decision-making with their partners? Did they have access to resources that would allow them to be able to go and spend time in a maternal waiting home if they needed to? What was the community support networks? How strong were they? Along the ways, it was availability, acceptability, and treatment by health workers. We could call those intermediate determinants of health, because we knew already that a number of women had complained through the zonal health department that they weren't really treated that well when they arrived at some of the health centers, that sometimes because they were late in coming, they were chided or kind of just not treated in quite the same way that they felt they ought to be treated. Obviously, geographical access is a big one, and the perception of how quality the service is. This is why we put a lot of emphasis on trying to upgrade all of the physical facilities of the maternal waiting homes that were part of our implementation study. There was also some discussion or awareness in community members about governance policy issues. So how well were the facilities being taken care of? How well were they being financed? How transparent was the financing of these particular facilities? Because a lot of them were based upon some kind of financial fundraising on the part of local Kibeles. What about the kinds of campaigns that took place? And obviously at a more deeper structural level, there were issues around gender norms and around health beliefs and about community practices. One thing we found a little bit unusual is that in all of our qualitative interviews and all the focus groups that we did, being aware that at this time there was a lot of political volatility in Ethiopia and in Jimma Zone itself. A lot of issues in terms of ethnic differences or conflicts or confrontations. Surprisingly, there was almost no mention of that as a problem. We would have seen that ourselves as outsiders, that this was a concern. I guess for obvious of their own kind of reasons around safety and protection, this was not an issue that was freely talked about.
Thanks so much, Ron. This is very, very helpful, and I'm hoping we'll come back to that in the discussion. So thank you very much. Now to our third round of questions. So to round up this conversation, could you explain how you think adding an equity lens and thinking through the concepts we discussed here today influenced how you were able to present your research findings to decision makers and how they use them for evidence-informed changes in policies and practice?
Okay. Our project has several equity-related questions. The first question that we asked within the project was, what was the feasibility of universal home visits, feasibility. Is it possible to even conduct universal home visit? So we were able to demonstrate and show that a program of universal home visit is possible. We were able to do it without any hitch, and we were able to complete it to the last minute. Another thing we did to ensure the issue of equity related is within the project is that we train government officials to manage and monitor the home visits. They took over management of the first wave of home visit, and they were able to run it for quite some time. So that means the government officials were part and parcel of us, and they were able to do that. The state government also committed to supporting the universal home visit so that they will spread it across other local government areas of Bauchi State, but as funding is available, that was the statement. So they were able to do that. Then another question we asked, which has some equity related, is what was the impact of universal home visit? What impact are we able to, get out of the universal home visit? The visit improved maternal and child health, even without increased visit to health facilities. That is one key results that we got. There were a lot of improvement in maternal and child health outcomes within the project. Then if services will be improved, if, for example, other services will be improved, it is great to do the universal home visit in addition to other facility-based health services so that the rural and remote people will be able to access health as they are supposed to, like any other group. Then what was the value of including male spouses, that is the husbands of the pregnant women? This also played a very significant impact on the male knowledge, and then their attitude has improved, and they really beat their wives, especially when they are pregnant. Even those that are not pregnant are now not beaten within those target communities. Then qualitative evidence that shows that we did show that the visit is gender transformative, at least it's gender transformative. And the important is because some intervention to increase male involvement may sometimes even increase male dominance and gender inequity. But in our own case, it's not so. It's able to, improve the gender equity. So those are some of the things we did under this project to ensure equity within the project.
Thank you so much. You really brought some very important questions, and I'm hoping we get back to those. The importance for policymakers, the focus on results, to demonstrate results and impact, which is what often policymakers would want to see. And then also the point about sort of having combined interventions or more than one intervention. We know that improvements cannot happen just by one intervention, and for the most part, especially in real life situations. So thank you so much for bringing up those points. We hopefully will come back to them later in the discussion.
Yeah, of course, from the onset, the end justified the means. We analyzed the context first of service provision, the context of clients, how they access care and the challenges from literature and from previous studies from the same areas. And we worked closely with stakeholders at regional level, at district level, the managers, at health facilities and the community. In that way, we were able to incorporate the context factors and designed the study in such a way we could reach our goal of making women receive appropriate, quality, timely care, as well as the neonates. So implementers at district level as well as in the health facilities, they started with identifying the challenges and what were the issues they could address at their own capacity, and what services and what support they needed from district level. So it was multi-sectoral, working district level, supporting the health facilities in implementing. And issues that were related to communities, the health workers communicated with the communities, with the scientists providing technical backstopping. So demand side issues like coming late for delivery, or booking late for antenatal care, or preparing to deliver at a referral place in case a woman was given a referral. So the community people are working so closely with the health facilities to make sure the information and the reminders were sent to that household, and the men also were informed, and there were repeated visits to make sure that the family was well prepared for delivering to the higher level facilities. And always the health facilities were doing analysis of their capacity to provide timely quality care. So each time they identified they were bottleneck, they were putting it in their plan, and they are communicating on time to the district level to make sure that they receive supplies and equipment to make sure that quality services was provided. So leadership at regional and district level, and through quality improvement, the service provision level, the health workers became proactive to make sure that the supplies and equipment were available, and they were encouraging each other to make sure that they provide the right services based on the nature of the women, because some women maybe were adolescent women needed special care and special counseling, or women with more than 5 or 4 children were also counseled that you should prepare yourself to deliver in higher level facilities. And so through quality improvement and working together with the teams at regional district level and health facility, as well as creation of champions at community level, made it possible to improve service provision and have best outcome at the end of the day. So it was not just specific question asking alongside the research, but studying the context and preparing the team to address issues in their plans, in their implementation, in their feedback, communication, and also supervision and mentorship for the leaders at district and regional level.
Thank you very much. This is a very rich response, and I'm sure it will be very, very useful for our audience, and we'll come back to hopefully again further to that in the Q&A. Thank you very much.
Thanks, Montessor. That's a really simple set of questions there. We're not exactly certain how, at least at the national level, our findings have influenced what their thinking is. We do know that we had several meetings over the course of this study with the National Advisory Committee, which was the national level ministerial people, some of their key experts, some of their senior civil servants. We used to attend those when it was safe for the Canadians during our site visits to actually be in the country. When it became a little bit risky for us to do that, the people, our partners at Jimmy University, made the presentations. And in the last presentation, the summary one, we got a series of questions back for more information from the National Advisory Committee members. Now, a key thing that we need to explore further, and which the Jimmy University people are doing at this very time, is they're trying to have a more in-depth discussion with the health center directors and health center staff. They're going to go out and meet with them all and say, this is what we found, because we didn't see striking kind of differences in terms of what our interventions were. We saw some, but not really striking differences for all kinds of complicated reasons in terms of the amount of time it took to get the intervention started, the political upheavals that were happening in the country at the time. But we did find that there were some very subtle differences between different health centers. And some did better than others, even though they had exactly the same kind of background or backdrop of resources, of policies, of programs, of interventions. Some did better than others. And what we began to realize is that there are some contextual features of local communities or local areas which allow some program elements to work better than in other places. This really kind of moves us into a direction of saying that if at a government level, you can't assume that a one-size-all approach to program implementation is necessarily going to fit in all contexts. There has to be much more nuanced understanding of what some of those dynamics are at local levels. That's very consistent with an understanding or an approach based upon equity rather than one that's based principally on equality. So we are kind of advancing the idea in the follow-up with the GIMA zone people, the zonal health department, with the National Advisory Committee members in the ministry, of the importance of more flexibility in programming, because that can address some of the equity concerns that our study began to observe. We also found, though, immediately, in a kind of, even as we were completing the study and completing the implementation, that our intervention, our implementation, education, and communication outreach approach that was part of our intervention, that was being copied by other zones besides in GIMA, other regions within GIMA that were not part of the intervention. They were really keen on wanting to do the same thing. So there was a dissemination on that. It sort of caught on. So you get this kind of little rippling effect. It's going to be hard to evaluate, but we think we have some really interesting little ripple effects happening in the country.
Thanks so much. Thanks so much, Ron. This is great to see how good stories propagate further and kind of expand. So thanks so much for your response. Very helpful, and hopefully we'll come back to that in the Q&A session.
Okay, you're welcome. Look forward to it.
Thank you all for being with us today for this very interesting session. We hope you enjoyed the first segment of the workshop today, which is introduction of the concepts and the interview of with our distinguished speakers. Our speakers gave us a lot of food for thought. They talked to us about how social determinants are affecting access to healthcare, in particular for women, and also how to do research to understand these social determinants and equity issues. They also talked to us about how, in their answers, about how norms are an important understanding the norms, social norms and social structures and social networks is an important aspect of understanding the determinants and the factors that influence health outcomes for women, especially during pregnancy and maternity. They also talked to us about how local context, how localized and contextual factors are extremely important for pregnant women, and to try to understand how they are, how the barriers can be removed. We now have time for our Q&A session, and please click and go to the Q&A segment of the on your screen to pose your questions. Maybe I don't see any questions at the moment, but maybe while we're waiting for you to type in your questions, maybe I'll turn to Mrs. Guidado and Dr. Labonte. You mentioned in your responses, made several references to community norms, and it's often the case in health research or where we, health norms are portrayed as only and always negative. To what extent have you had some, Ron, you mentioned specifically earlier about sort of solidarity and about some of the other concepts, so maybe to elaborate a little bit on how social norms can also be, with the right understanding, and then they can be kind of an enabling force as opposed to a deterrent of access to healthcare for women.
Well, there's really, thanks, Monteserva. There's not too much more to add to that. I mean, the norms that are essentially positive social relationship norms, right? So they're norms that, and we've heard from the other projects as well, the kind of the degree of support, the degree of caring, the fact that to some extent they got institutionalized in Ethiopia with the creation of the Women's Development Army, with the 1 to 5 kind of Tokoshani process of trying to have model families. But ultimately it's about the extent to which people have a developed sense of responsibility towards each other. This sometimes within the program manifests with people contributing a small amount of money that would then go into sustaining things like the development of the maternal waiting homes and sort of upgrading their capacity. But I mean, there's a lot of poverty, and so that it's more in terms of what people contribute, what they can to each other. I mean, we were quite surprised to see the extent to which health extension workers and people who are working out of the health centers sometimes would give some of their own earnings, some of their own resources to particularly poor families. I mean, that's a human attribute. That's something that can either nourish or it can be suppressed within communities. It's a bit awkward for me to sort of mention this, but at the same time, we know that the ethnic tensions that have existed within Ethiopia, that would be a kind of a deterring community norm, insofar as that would sort of make it more difficult for people to feel safe or secure within their particular areas. So that we have a bit of a dialectic going on in Ethiopia at the time.
Thanks so much, Ron. Mrs. Guidado, would you like to add something to this point?
Yes, I would like to add something. In our own case, in this project, what we did was to ensure that we recruited those that are going to work within the community, and they were selected by the leaders, the community leaders. Initially, actually, we found out that we brought some people from somewhere because we felt that they don't have, people who can be able to do this work, especially when you are using handsets and so on. So we just underestimated and thought that maybe we won't find, qualified people to do that work. But surprisingly, when we talk to the community leaders, they say, well, they have their young wives, young women, and children who have completed secondary schools. Some of them are married, living within the community. Some of them are doing no job. So they still thought that this group of people will be able to do the work. So we then told them, okay, bring them in. So we brought them. We had to increase the number of days they are to be trained. Initially, we were training for just about 3 days. We said, okay, in their own case, let's increase the number of days to 5 days. And then we were surprised that, even within those communities, there are people who are capable, who are intelligent, who will be able to do this work. And we brought them in and they did all the work. We were working with the community leaders hand to hand, because right from the beginning, we made sure that this project is their project. So they, right from the planning stage till the activity time, they were part and parcel of the project. So they became so interested. In fact, there is a community where they constructed a road to the maternity. The maternity was, it's not quite far, but it was very, with a lot of, there was no good access. So the community people came and, in one day they just made road which will link to the community and so on. So when you give the community the hope that they are also people, they will also be able to help themselves, they are going to do quite a lot. And there are women groups. After we are completed, when we are doing this dissemination, we do the dissemination at the community level to women groups, to the community leaders, as well as the local government and so on. So by the time we were doing those activities, they all embrace, and then the women group are now, they are doing some petty trading. They don't have the resources, but they were able to put some money together, and they said, if we pull out, they will ask those girls to continue with this work because it's really helping them in the community. So community norms are nothing but carrying them along, talking to them all the time, being with them, giving them all the opportunity, respecting what they respect and so on. So I think that's what I understand all about community norms, and then how we'll carry on with the community actually. Thank you.
This is very helpful, Yagana. These are really also great points that complement what Ron just mentioned. Dr. Manzi, do you have some views on this, on how in your research social norms were an enabling factor or were enabling force in your research? Was that a factor in your work?
Yeah, in our research, of course, yeah, there were a lot of social norms, and even the health system itself has its norms. So the interaction between health service deliveries and the community system, where we emphasize on the issue of social-political structures. At each level, they identified the root cause of why women coming late, why they are deaf, why services are not provided as needed. So through the use of quality improvement approach at each level, from the community, they could understand based on their context, how they can reach the less well-off members of the society. The health facilities, instead of the norm of just sitting and waiting for the leaders to come and check what was missing, they started to be proactive, to plan, to review their own work, and proactively work towards addressing the challenges in service deliveries, if there were some stock missing, if they needed to support each other, if they needed to change the working time, it was within them. And the leaders at district level as well, they became innovative in the way they supported service provision at health facilities, follow-up, supervision. Even when they missed the maybe car in the morning, they could now themselves arrange to go in the afternoon to meet the facility health workers and discuss the way activities were carried on and services provision, and also met with the champions at the community levels who were also stimulating and encouraging women to seek care at the right time.
Thank you so much, Dr. Manzi. Just reflecting on what you all just mentioned, it comes to my mind the point about sort of capacity building. Several of you talked about community health workers, talked about training teams going on the ground and to do the work with the women, whether in terms of information or in terms of using research tools or methods. Have you found it? How did you get your teams to really absorb the issues or the concepts of equity in what they were doing? What kind of training did you give them, or orientation did you give them to understand the concept and to understand the relevance of it in its relationship to the questions or their role in the field or in the research project? Dr. Manzi, you were just on the Ron. I see you unmuted yourself, so please go ahead.
Okay. We actually, in the early stages of trying to get our program going, we spent a lot of time in training, and this was a very participatory approach to training, because we had an extensive qualitative component with a lot of focus groups, a lot of different individual interviews, so that we had a whole lot of field interviewers from the university that we needed to make sure that they had a good grasp of qualitative technique. And in running that course, we paid attention. We had sessions that looked at gender equity. We talked about issues related to equity or equality. We had them undertake exercises, hands-on, and then debrief. We had them interview each other. We had them sort of basically go through a whole lot of processes that underscored the issues of trust, understanding, reciprocity, kind of what equity actually means in a social relationship. We also interviewed our data collectors, and so they became participants as well, because we realized that they had an enormous amount of observational knowledge. So what they saw in terms of how focus group dynamics took place, who spoke, who didn't speak, separating the groups as well, so that we would not have village leaders, for example, in some of the groups, because we knew that once a village leader participated in a group, all the deference would go to the village leader, and everybody would basically follow on what that person was sort of saying. So there were kind of understanding about how we could sort of increase or improve the environment around which people were able to speak freely. Yeah, it was quite a fascinating set of experiences in terms of sort of working with all of these different people.
Thanks so much, Ron. Fatuma, would you like to come in on this point?
Yeah, for us, we had a set of course, for health facility, we had medical personnel, scientists, and our capacity building, of course, for the team, they attended various trainings, but for the implementers at district and health facilities, we had learning sessions and were kind of brainstorming meetings. We selected challenges that we are facing provision of maternal health, and we discussed the root cause. And in that way, we were able to unveil the root causes of poor service provision. And the health workers were capacitated to be able to analyze other related problems as well. And this was repeating every 3 months. They were coming together to learn from each other, because some facilities were ahead of others in identifying challenges and addressing them, and others were learning. And so it was learning, giving feedback, and sharing experiences. And at community, the leaders had their own brainstorming session, where they were also called learning sessions, and the community sessions were led by social scientists. Also, we brainstormed the challenges facing the community members, because household, although they're in the same village, by this, there were some who were very remotely, some were very poor, and also we had discussions with leaders of women groups, and in those women groups, the not well-off women were not there. So together with the community people, we could brainstorm how to reach those people who were not really showing up, even in services, in social groups. They were not coming even in meetings, village meetings. So working closely with the leaders in the villages, women members, and in that way we were able to reach those who were marginalized and those that needed special attentions. And through capacity building of the team members, the research scientists, as well as leaders at the district, we were able really to address issues of equity. Thank you.
Thank you very much, Fatuma, for your response about how that worked out in your context. Yagana, in your context, how was capacity building? How your capacity building of your team there sort of helped them to absorb the concepts of equity and inequities, and how that was, to what extent that was reflected in how they carried out themselves and carried out the work under the project?
Yes, the concept of equity was really carried out within our project, and especially when we said we are going to do universal home visit. Universal home visit simply means not leaving out any house, and that is, we use GPS location with the GPS, and we have told them that if you don't go into any house, the GPS will show, and you will not be paid, you will be penalized, because we are giving them some kind of stipend. And then the stipend is based on performance. If you performed well, you will get what you are supposed to get, however little it is. If you don't perform, if you don't do the work properly, you can be given. Initially, we had problem with, they thought that how can they see us? Is it because this handset they will see us? No, they won't see us. So they started, the initial stage, they were forging. They just sit down under a tree and then record so many pregnant women and so on, and they brought it. Then we looked at on the GPS, and we discovered that some of them were sitting down in the clinics and doing the work. So we said, no, we can't take. We showed them actually on the GPS location. They were shocked and surprised. Is that so? So we said that is how it is. If you do, at the initial stage, we got about 30-something% invalid record. But when we showed them the GPS, and then they understood the concept very well, and they know that we are going to see them, so they started doing it properly, and we saw the data spread all over the homes. So, and we have also instituted a quality check, where if they go into the community and then they didn't spend the number of minutes required with the pregnant women discussing the issues, the handset will give a stop. It will show that they hasn't done the number of minutes that is required for this activity. So we also saw that, and we said, okay, you haven't spent enough time with the pregnant woman or the husband. Therefore, we are not going to pay you. We'll just say this is invalid data. So from there, we were able to discover that they are really going into each house. They are really spending the number of time that is required to discuss on the issues that are within the handset. And we were able to get everything going. And then during the training, we have also trained them on privacy, because you know, you cannot just go in and then stay within the family level and begin to discuss issue of pregnancy with a particular pregnant woman. So we said you have to observe privacy, if possible. That is why they are women. So therefore, they can go into the rooms of the women, they sit down and discuss with them, and then they will feel free to say all what they want to say. So that has also helped. And then apart from privacy, we also have consent. They have to take the consent where they have to talk to the women for them to agree to participate or not to agree. Usually, if the women don't agree to participate, by the time they go into several other houses, the woman will send to them and say, please come back. I learned this thing is, you know, being accepted by everybody. So come to me, I will agree to do it. So eventually we got no one missed. And then we are working closely with the local government authority. We have already have some supervisors from within the local government who are assisting us to, you know, do the work. And then universal coverage actually needs a lot of monitoring. If we are to do the monitoring, and you can monitor every household just physically, but the electronic monitoring is a very good system of monitoring everything. And then they send all the all the, you know, data to our server, which can be downloaded within within every day we download. Our data manager will download, we'll sit down as a team and discuss. And if there is issue, we go back to the workers. So we really got a quality work, and that has given the universal nature. And then community involvement is very, very important, because we had to involve the community from the local government level to everybody. They all became part and parcel of the project. So we worked together with them. Then visiting the men, because men are the decision makers in the family, especially in our own type of, you know, community. So carrying them along means a lot, because we also, you know, gave them all the information we are giving to the pregnant woman. Your wife is pregnant, yes, you will say. Then these are the issues. This is what we will discuss with him. And we are also going to discuss the same thing with you, so that you would work together to improve on her health. So eventually, we were able to give equity, you know, care, and then we also are able to also give gender equity as well. So this helped us a lot to get to where we are. And we were able to get very positive. And our data shows that, the analysis shows that really there's improvement on maternal health and infant health, and then reduction in household diarrhea, immunization they are undertaking. Even though we don't ask them to go to health facility, we have talked to them on danger signs of pregnancy. So when they see danger, they go to the hospital. In fact, husbands are now carrying wives to the health facility by themselves, which is a lot of improvement.
Thank you so much, Yagana. This is for those who, I see a few people have joined the webinar now. We're at the Q&A segment of the webinar, and my question was about sort of the capacity building of the research teams and the community health workers, and how the concepts of equity were integrated in the training and the rollout of the work. And Yagana, one of your points are really well taken, and especially the point of not only it's important not only in terms of the training of the research teams and community health workers to integrate the concept in their concept of equity and the intersectionality in their training, but also to monitor that and to make them understand how the continued application or understanding of this concept or the relevance of this concept in their daily work, daily research work is important, and it's monitored and supported by the research team. This is a skill building workshop, so hopefully this will be very helpful for our audiences. I would like to see welcome questions from our participants and guests today. So please add your questions to the in the Q&A section of the session. Dr. Manzi, I'll go back to you because in your earlier responses, you talked about the culture of data use and quality. And that is so important. That was so important in your research. You emphasized that, and I'm sure it's important in every research. But maybe if you could elaborate a little bit more about how did you build that sort of culture of rigor and quality data and use? How did you build that capacity in your team, and how that helped to understand generate information, solid information to understand the understand social and health differences?
Yeah, we had a component of using tablet to collect health management information system. The indicators we developed together with the stakeholders, of course, from Ministry of Health, regional, district, and we were involving also the health workers. And in our team, we had a data manager. This is a computer scientist and a good data manager. So after developing the various indicators, they were programmed in tablets where each facility had one tablet, and health workers were trained at their point of service delivers. It was not a class training, but the data manager went in all the implementing health facilities to train the people. And then we developed a screen. This is where health workers could see the summaries of performance of various indicators, ANC, PNC, deliveries, and also in changes in the availability of supplies and equipment, and if those things were functional. So this could help the health workers to really understand their position and to use the data to discuss, to come up with actions to improve, if it was to add in their plans or to use local available resources to purchase those things, supplies, basically supplies or small equipment that were needed to for them to provide quality care. So the data manager was also always available through these mobile groups, mobile system. Of course, we also had WhatsApp group. Some issues, data issues were discussed there. And we had frequent, I can say, quarterly feedback with the district managers and regional to show them how the districts were faring and what were the improvement and what areas were not improving over time. And of course, the regional were also there, and because they were the leaders of the district, they emphasized and reminded the district and health facility to make sure those issues were addressed so that women get the right services at the right time, to make sure that women and newborn were surviving, more surviving. Yeah.
Great, thanks so much. Maybe now we go to Mrs. Guidado to ask the same question. You know, kind of ensuring the data, not only the data quality and rigor, but also the data use. How did you go about that in your project? I think you're on mute.
Okay, so when we get the data usually directly from the Android handset the boys and girls are using, when they discuss everything with the pregnant woman and the husband of the pregnant woman, this discussion will directly come to they will send forward it to our data. Then we download, our data manager will download, and then we'll sit down and look at the data. Then we'll be able to see whether things are going properly or if there's any problem. If there's any problem, immediately we ring back through the telephone to the worker that you have not done this or that. For sometimes they may not, even if they go to the community, probably they didn't go to the right place, or they have maybe, instead of using a particular, because they also have what we refer to as index number. So the index number probably, instead of using for that house, she used it for another house. Then if such issues are seen, we immediately ring her and then redirect her to go to the proper house so that she will do it again and then send it back to us. So we are doing a lot of data analysis, and that almost daily, the whole team, because it's a part of training. If we all sit down and look at the data, not only just the data manager, but all the program officers will be there. Then we discuss it, and we have supervisors who are attached to each worker. So the supervisors will also, once the data manager gets the data, she will forward it to the supervisors, and all of us, including the program manager and the whole IRT team, will sit down and look at the data. So this has given us a lot of information, and then the data is accurate. Where there is problem, we always redirect them and talk to them. But alhamdulillah, at the beginning, we had problem, but as time goes on, we became so perfect that we don't have much problem with the data. So that is, yes, thank you.
Thank you very much. Dr. Labonte, your...
Well, I might add a little bit, yeah, a little bit about around the data. We had our kind of implementation study actually took off in two different directions. They were very much related, and they would always come together. But we had a team that was really focused on qualitative data gathering and analysis. So that we did a lot of kind of pre-intervention kind of data gathering. We did a baseline qualitative gathering and an end-line qualitative gathering. And that was pretty extensive. We're talking about hundreds and hundreds of people who were participated in focus groups or in interviews. And in that respect, we did a 7-day intensive qualitative data workshop at the beginning, and that very experiential, quite a lot of fun. In parallel, there was a quantitative component, and that quantitative component had a very lengthy, kind of very detailed survey, and that involved as well training of all the field researchers who would actually implement that, again using GIS, using the same sort of systems that other projects did around positioning exactly where these surveys were taking place. That stuff was always then daily uploaded into the cloud. There were data quality monitoring that was taking place on a regular basis. I can't really speak too much to how the quantitative component was done, because that's where other colleagues were involved in really managing that to a greater extent than I was. On the qualitative, once we got the data in, it was a question of then doing a lot of skill training or upskilling, as it were, around how do we undertake qualitative data analysis? What sorts of software programs can we use? A lot of that was run by one of my PhD students here in Ottawa, who then worked very closely with some of the PhD students who were involved in the research at Jimmy University. Really a very healthy collaboration back and forth in terms of looking at the data, sitting down side by side, trying to sort of figure out how to do the interpret, how to create the coding guide, how to do the the analysis, what inferences to draw from that. And we had a lot of different qualitative researchers undertake the analysis of the various transcripts. So there was a lot of quality assurance, as it were, in terms of the evidence that came out of the qualitative side. On the quantitative, I mean, the people who were involved in actually doing the analysis, and we had a PhD student at the University of Ottawa who's just completing now, Jamita Kurji, who she really kind of ran that particular component and did an extensive job in terms of assuring that the quantitative data analysis was really sharp, really focused. It included an extensive review of all the strengths and limitations of previous studies. So in terms of the data that we've generated, I think that we feel really quite pleased with the amount of hard work that went on. That was also on the part of the Jimmy University people who were doing a lot of that work, and the folks here in Ottawa that were working on it. So in that sense, I think we had a really credible undertaking of data analysis. Now, did the data actually prove that our interventions worked? That's a different question. That, as I think I mentioned a bit earlier, some of our results were not quite as stellar in the direction that we wanted them to go in for complicated reasons to do with the disruptions in the country, the very slow pace at which the interventions were undertaken. But, and again, as I emphasize, the subtle point that there are some geographic areas that we know where there were some subtle differences, and we're trying to explore those a bit further, because that could reveal far more context-rich information about why it worked in some places but didn't work quite so well in others.
Thanks so much, Ron. While we have you on the screen, Ron, we're now at the last segment of the webinar, which is really to ask each of our distinguished speakers to give one or two key messages on how your team learned on integrating to leave with our audience on what you want them to take home in terms of one or two key messages on regarding integrating equity in research projects, especially in relation to maternal and child health. So we start with you, Ron, since you're on the screen already, with your one or two take-home messages,
kind of do's and don'ts. Well, they're not quite just one or two, but just a couple. I think an important one is to think beyond gender in terms of being the only issue or stratifier around equity or equality. We found that income was important, geographic location was important, community relations and social supports. They were all important. So really take that a really nuanced intersectional approach to understanding equity. Use data collectors as a source of additional data. Now that's something I've already mentioned, but we kind of rather uniquely interviewed our interviewers after they returned from the field. And that became a rich source of interpretation and understanding of what some of those equity elements or dynamics were. Check our findings and interpretation of all the data with the program implementers. I mentioned that's now underway with the staff at the health center level. So they can say, well, this is what we found, this is what we didn't found, this is what we're confused by. They have a very detailed EMIC, kind of like local knowledge, and can help us in terms of interpreting why things worked when they did and why things didn't work when they did not work. I could also sort of say, given that the kind of upheavals that we experienced when we were there, and kind of at one point we all had to leave rather suddenly out of the country because of the unrest that was going on. An important do was always plan for the unexpected. A couple of important don'ts. Don't ignore the importance of extensive qualitative engagement with communities. Now that's partly using local community people as part of your researchers as well as just participants, but it also means for even in-country researchers as well as the we internationals who come in and sort of try to do a little bit of work with local partners, that we spend time in terms of understanding more about what the local communities are. But a really important don't promise more than can be delivered. So don't raise too many false expectations. This was an implementation study. I know our National Advisory Committee was a little bit disappointed and said, well, what's the big public health contribution? Because we haven't seen a huge difference. And I said, well, sometimes when you're studying something and you're implementing it to see if it works, sometimes it doesn't work the way you'd like it to. That's an important public health finding.
Thanks so much, Ron. Very wise and very helpful. Fatuma, your one or two do's and don'ts, key messages you'd like to leave our audience with.
Yeah, in order to reach the disadvantaged and all groups, it's better to involve the socio-political systems because it's not one system that can address the problem, but these multidisciplinary teams, they can think from different angles, from the community. These ones, with technical backstopping, they can address local challenges. And for example, as we use the champions, this real, they were able to use the quality improvement approach to address issues of maternal newborn health. And sometimes they used for other things, for education, children who could not enroll in schools. They used the same methodology of understanding the root causes, and they said, this time we address a lot of challenges without jailing parents. So they used the approach to address other determinant of health, like education and other issues in their villages. And the don't is like, don't go as a scientist with your design, you have to involve stakeholders. It's very, very important. Those people are involved, they know their peoples, and they know best ways with technical backstopping. Together you can come with ways to reach the very remote people and those people that many times are not covered with services.
Thanks so much, Fatuma. Being inclusive is a really great value, of course, to guide the research and the quality of the research. Thanks so much, Yagana. Your
Yes.
do's, don'ts, key messages for our audience.
Okay. There are three main do's. Universal coverage is one sure way with GPS use of a handset enabler. If you do that, you will surely reach every nook and cranny of the community and ensure that no household is missed. Then the second one is involving the community themselves, those affected, those women who are part of the problem, they need to be discussed with. That is why we are talking to every pregnant woman. So ensure you talk to all the women, you talk to all the spouses of the women, you carry along the community stakeholders, and then the state stakeholders work hand in hand with them. If you do that, you will achieve universal home visit. And then the third one is visiting the men, talking to the husbands. The husbands became part and parcel of this activity. Whenever we talk to the wife, we talk to the husband. He is the decision maker. If you don't talk to him what you spoke to the wife, next time when you come, he will say, go out. What are you talking to my wife? But when you talk to the wife and then talk to the husband, you have created a forum where they will communicate. When he comes out, he said, what these people say? Then she will also say, this is what they told me and this is what they told me. So they become friends, they communicate to improve on even the health of the family in total. The don'ts are, don't give handouts. Don't give handouts to the community. Whenever, you know, they keep asking us, your other people, when they come, they are bringing Omo, they are, you know, soap, they are bringing this and that. We said, no, we are only bringing knowledge. We want you to have good knowledge, good concept on what we are doing, and then help yourself to become part of it and then improve on your health. So these are the brief that I have for do's and don'ts. Thank you very much.
These are incredibly rich lessons and experiences, which we're very grateful. I'm very grateful that you have given the time today to share with us. In just a few words to close, to thank you very much for our distinguished speakers presenting very rich experiences, and to thank our audience for being here today as well. You know, equity is important not only as a research concept, but also as a value, as we have heard from our speakers. It will look and mean different things in different contexts, but we hope that research helps the society to understand what it is in that, what equity is in that context, and what can be done to support it among all the populations, especially marginalized populations and people who don't have access to resources like other parts of the population. We need to embrace the concept further in future research, whether this research relates to sexual and reproductive health, maternal and child health, or epidemic or pandemic preparedness and response, like the period we're living in now, as I mentioned in the introduction. Both communities and decision makers need to be involved. You know, as the examples given by our speakers noted, you know, the value of research is not only in terms of generating information, data, or knowledge that is put on the shelf, but it is to be used, whether positive learning about things that work or negative learning about things that did not work or proven that they did not work. These are all knowledge. All knowledge is useful, important, and helpful for decision making. At times, this includes a formal requirement of including a decision maker, as the case of IMCHA, but this is also, and this creates an important, helpful model of how to shorten the distance between research and use of evidence. We have the sort of example of in IDRC, we support and work with researchers in low and middle income countries to find solutions to unblock health challenges in their communities and regions. The research questions we fund come from people in low and middle income countries with the most knowledge of their own context, which we think is key to finding innovative solutions that are sustainable and scalable to the interactable health inequalities that we see the world over. We hope you found this webinar useful in terms of building skills, building knowledge, and learning from experiences from the field, that this would be useful for your research and for your policy work if you're a decision maker. All of us here today would be more than happy in the future to continue this conversation and provide additional information. Thank you very much for our speakers and for our audiences, and we wish you a good rest of the day. Stay safe and best of luck. Thank you.
Thank you.